Hello, everyone, and welcome to COPD and Medicare Made Simple, Understanding Your Benefits. I am Johnny Karinko, a respiratory therapist and educator here at the COPD Foundation. Today, we are joined by Erin Bradshaw, the Executive Vice President for the Advancement of Patient Services and Navigation at the Patient Advocate Foundation. She will guide us through how to manage common issues that people with chronic conditions may experience with their insurance. I'm going to pass it over to you, Erin. Thank you very much.
Thank you. Well, welcome everyone. It's a great opportunity to share some information today on Medicare and try to make it as simple as I can for you to help you understand your benefits. So for the agenda, we're going to do a brief overview of Medicare and insurance. I'm going to talk a little bit about parts and plans, some key considerations for plan selection and enrollment periods, some cost-saving programs, and then I'm going to reference some case studies that can bring real-life examples to you with some resources and suggestions on how we would navigate those challenges. So first, what is Medicare? So Medicare is a federal health insurance program that is overseen by CMS that is for a select group of people who are typically over the age of 65 or disabled through Social Security disability and have been on benefits for 2+ years and or have end-stage renal disease that requires dialysis and transplant or have an ALS diagnosis. So Medicare is broken into different areas of coverage. They're called parts that I'll be going into in a moment. Medicare is individual coverage. So even if you have a family, you would have to purchase individual plans, and there will be cost associated to those to each person. So I'll pause for a minute here because we're going to be talking about Medicare, but it is important that I also share that you have public benefits and you have private benefits. So Medicare falls under, public benefits as well as Medicaid, and the government plan like TRICARE or military benefits, whereas private plans, you can get them through employers, an individual marketplace, and such. So some people might have Medicare and other insurance plans, or you'd be transitioning from one plan to another. So Medicare is a bit complex. But this graphic is giving you an understanding of how it's designed. So you have Part A, which is hospital coverage. So it covers your inpatient hospital services, your skilled nursing facilities, hospice care, blood transfusions, home health care. There is a separate deductible and out-of-pocket expense associated to these charges. Then there is Part B, which is medical coverage. So consider this the part that covers your physician fees, your durable medical equipment, some outpatient services, maybe rehab, things like that. And there are certain medications that are covered and grandfathered in under Part B. Part D is your prescription drug plan. It is a voluntary benefit that covers your outpatient prescriptions and can sometimes be combined with a Part C, also called Medicare Advantage. So that leads me to Part C, or Medicare Advantage. This is the same coverage as original Medicare, which is Part A and Part B together. However, it has some advantages of having the coverage collectively together under one umbrella through a private insurer that can also encompass your Part D or prescription plan. So let's move into some key considerations for choosing the right Medicare plan for you and some very important enrollment periods that I want you to be familiar with for initial and annually so that you can continually look at your plans to meet your goals. So key considerations when choosing a plan would be cost. many people are making choices on the type of plan that they're selecting based on that principle. So what would that be? That would be your premiums, your deductibles, and other out-of-pocket costs. You also want to make sure that the coverage is suitable for the services that you know you need and you project that you might need, as well as the providers. So are there current providers that you're seeing, or facilities and pharmacies, or ones that you wish to go to, and making sure they're part of the plan network. And then prescriptions is checking the plan formulary to see if the coverage that they offer covers the current prescriptions you have, and also looking at the cost associated to each. I strongly recommend that you take the time that you need when you're making these decisions. It is a very complex and sometimes confusing process, and there are resources out there that can help you. I'll be sharing those at the end of our presentation. So here's a great visual that just shows you the differences between the Medicare options. So as a reminder, Medicare A and B falls under what we call original Medicare. You can choose to keep that independently and then add a prescription Part D plan to that. And you can also choose to elect a Medigap plan, which I'll go into shortly about those eligibility guidelines. Or you might choose to pick a Medicare Part C, Medicare Advantage plan that would encompass your A, B, and D. And then oftentimes they carry additional benefits that traditional Medicare may not, like dental or vision. So as you weigh your options, some of the things to keep into consideration is that with original Medicare, there is no prior approval for services. As long as a provider accepts Medicare as assignment, you can go see them. Versus a Medicare Advantage plan often will have a network, and depending on the type of plan that you're looking at, it could be a PPO plan with a little broader network opportunity versus an HMO plan that might have a more narrowed or restrictive authorization process to see a specialist. Also, original Medicare, most providers do accept in the US, whereas with Medicare Advantage, they have, as I mentioned, a smaller network of providers where they have contractually agreed to be part of that plan. Original Medicare, on the flip side, has no out-of-pocket cap. So which that means is that there is no ceiling in which your expenses would be capped to, unlike Medicare Advantage, which has a maximum out-of-pocket cap. And it varies depending on where you reside, the year, and the plan. But at least you know, like with traditional health insurance that you might get through an employer or such, that there is a set cap that you will not exceed if your expenses and your care was to be at that level. And for original Medicare, there is no coverage for benefits like eye exams, dental care, or hearing aids, whereas Medicare Advantage might offer those additional benefits. They also might offer benefits like food delivery or transportation services. All these things are important as you do an analysis of your plan choices. So Medicare initial enrollment period for those of you that are turning 65 is 7 months long. So it's 3 months prior to your birthday, the month of your birthday, and then 3 months after. You have this entire 7-month period to choose your plan. If you choose it in the first 3 months, then your coverage begins the first day of your birthday month. If you choose it on your birthday month, the coverage begins the first day of the following month. And then the 3 months after your birthday month, the coverage begins the first day of the month following the month that you enrolled. So this is called initial enrollment period. This also applies to those that are disabled under Social Security and receive the SSDI benefits. After 24 months, they are eligible for Medicare enrollment. The same rules apply, and then they can proactively enroll, and it becomes effective on the month of their eligibility. I wanted to briefly touch on Medicare eligibility for those that are working, whether it's themselves or a spouse, because depending on where you get your health insurance and the number of employees of where you work, you may need to sign up for Medicare when you turn 65. There are circumstances where that isn't necessary and you can actually wait, but it's important that you speak to your benefit administrator to know what the expectations are so you do not find yourself in a situation where they're classifying themselves as a secondary and you don't have the primary insurance under Medicare. Medigap plans have guaranteed issue periods. And I wanted to bring this up because it's something that it's an important tip for me to share with you is that it is 6-month period that starts the month that you turn 65 and you have both Part A and Part B. And I bring this up because if this is something that you're interested in, this guaranteed issue protects you from a plan excluding you for pre-existing health conditions and also is sold to you without restrictions or increased premium rates. So if you are someone who likes to travel or you want the flexibility of being able to go to any provider that accepts Medicare, or you simply just want to understand what options that you have, I encourage you to look at this supplemental insurance along with Advantage plans to weigh your pros and cons on the benefits of each. A Medigap plan is just what it is. It's a supplement. So supplemental insurance is secondary coverage that will cover Medicare approved out-of-pocket costs that are your responsibility. So co-payments, co-insurance, deductibles. It can get complicated because just like the alphabet soup we talked about earlier about A, B, C, and D Medicare, Medigap plans also have alphabets. And so each plan design is different and is reflective of the coverage that it provides. And I encourage you to seek some support or, look at those options when you're considering. So the second enrollment time is called an annual Medicare open enrollment. So there's 2 open enrollment periods every year. The first one is the annual election period that runs from October 15th through December 7th. This is the first opportunity you have to make changes to your coverage. You can switch between your original Medicare or your managed care plan, so Advantage plan. You can switch between Advantage plans. You can also add, change, or remove your prescription Part D plan. The second opportunity is for Medicare Advantage. So you carry a Medicare Advantage plan, and that open enrollment period runs from January 1 to March 31st. During this time, you can only return to original Medicare and add a drug coverage or switch between a different Medicare Advantage plan with or without drug coverage. There are special enrollment periods. So say that you stopped working or lose your health insurance coverage, or you've moved out of a plan's coverage area and no longer have access. You have lost your current medication coverage, or you're moving into a nursing home or skilled nursing facility. All of these things are considered special enrollment periods and open up the window for you to select different plans outside the 3 options I shared earlier. So let's talk about managing out-of-pocket cost. I'm going to talk a little bit about some of the programs that I think that everyone should screen themselves against. So there is a Medicare Part D Extra Help program. What this is it helps with the cost of your prescription drugs, like your deductibles and your copays, for those that are eligible. I've put the income and asset limits based on 2024, which is how they base this information for your knowledge. But as an individual, you'll see that the income cap is $22,590. The resource limit is $17,220. For a married couple, The income limit is $30,660, and the resource limit is $34,360. You can apply at Social Security for this benefit. And if you don't know if you fit, I encourage you to do that because they'll do the eligibility screening for you. Likewise, there is a program through the state called Medicare Savings Program. There are 4 types of Medicare savings programs, and if you're eligible for these programs, they might help you pay for your premiums, your deductibles, your coinsurance, and copays. And eligibility is based off income and resources. I did not place the income and assets here, and I encourage you to look at them for eligibility. One of the things I will share is if you do apply for extra help, it does screen for Medicare savings and vice versa. But it's always good idea to take a look under your state Medicaid and evaluate your eligibility. These are great programs that many people don't know that they're eligible for. There have been a few things with Medicare Part D that have been recently changed for 2025, and I want to call it a couple of them in our presentation today for your awareness. So beginning in 2025, what we call the IRA, dramatically reduced the out-of-pocket cost for Medicare Part D beneficiaries who currently spend more than $2,000 on their medications. For those of you that are or not familiar, this was the process of closing what we call the donut hole that had started many years ago when prescription drug coverage came into the market. Historically, prescription coverage was not covered under Medicare, so this was a new addition for a much needed benefit for our Medicare population. As you see here, Jill, in this example, in 2023, had over a $10,000 out-of-pocket expense, and in 2024, over $3,000, and moving forward in the 2025 year, she is now capped out at $2,000. So in addition to this benefit, there's also what they call the Medicare Prescription Payment Plan. So what this is it allows people with Medicare prescription coverage, so Part D, to pay their out-of-pocket prescription cost in monthly installments instead of all at once. This applies to people on Part D as well as Medicare Advantage plans that offer Part D benefits. So let me explain this a little bit more. You've also might have heard some terms like smoothing or MPP. These are the key features for this, how this works. So they spread the out-of-pocket drug cost across the year. And then you voluntarily, as the Medicare beneficiary, must opt in. You can enroll before the plan year or at any month during the year. Then the enrollee pays $0 at the point of service they covered the Part D drug, so the pharmacy. The bill comes from the Part D health plan for the incurred out-of-pocket cost, and then the amount for each month cannot exceed the maximum monthly cap. So let me show you what this looks like. So smoothing is the flexible tool for Medicare beneficiaries, and you'll see here that it's not fit for everyone. So in the example on top, you see the patient was prescribed a $500 a month drug in January. They opted in. And so that was broken out into a payment plan of $166.67 over the course of the year. In example 2, the patient was prescribed a $500 drug in September and opted in. Well, you see here that with the $2,000 cap, the next 4 months is equal to the $500 out-of-pocket cost. So really is no cost savings here for that person. And this could apply at all different levels. So when you look at this, you want to be certain that, you understand entirely how this is working, because it is a great value for some, and for others, it may not. So let's go through a case study. So what should Joanne do? Should she opt in or not? So Our analysis is probably not. And the reason is since Joanne is enrolled in low-income subsidy, her prescription costs remain low. The new Medicare prescription payment plan would likely provide minimal benefit to her. She may prefer to continue paying for prescriptions up front as she has done in the past. Again, this is a very individual choice. So I am going to talk about 4 different case scenarios that are about prior authorization, formulary, and out-of-pocket cost. And I'm going to bring in some resources and suggestions as to put yourself in the shoes of these individuals, and hopefully that they can be a beneficial help to you. Lisa is a 60-year-old. She's enrolled in Original Medicare. She carries no supplemental insurance, and she is faced with a high coinsurance under her plan that is making it very difficult for her to access the full course of pulmonary rehab that is contributing to her uncontrolled COPD. Her issue is that her pulmonologist strongly recommends she participates in this pulmonary rehabilitation program to help manage her COPD. While Medicare Part B covers the rehab, Lisa is responsible for 20% of her coinsurance for each session. On her fixed income, on Social Security disability, she can only afford to attend a few sessions, which is not enough to be effective in the management of her condition. Without regular rehab, Lisa's symptoms worsen, leading to increased hospitalizations. So let's talk about a couple key terms. So while we were talking about coinsurance, that is a percentage of the health and care item or service that you're responsible after you've met your deductible. In this case, with Medicare or Original Medicare, your coinsurance is 20%. So if the rehabilitation service was $400, she'd be responsible for $80 for each session. Now, the challenge with this is that there is no out-of-pocket maximum, which is the fixed amount you pay for medical services in the plan year. This applies to the copays, coinsurance, and deductibles that are paid by the patient. So that can lead to a very high out-of-pocket expense for someone, especially on a fixed income. If she was to receive copay, that would be a fixed dollar amount that you would add to the service, which could be $20. So even if the visit was $400, she would have a $20 copay for that each and every visit. Often these are applied at the receipt of treatment. Deductible would have to be met, and for Part A, it is $1,676 annually, and for Part B, it's $257 before, and Part D is $590. And then, of course, premiums, I have them referenced here, but it's the fixed amount that you pay each month to even have insurance. And this varies depending on the Advantage plan you have, but there are fixed rates that change annually for Part A, B, and D. So as we look at her care needs, and this will fall under Medicare Part B, there could be a possibility that she would accumulate not only a coinsurance of 20%, but also a fixed copay. So if she gets services in a doctor's office, she'll pay the 20% of the Medicare approved amount. If she receives services in a hospital outpatient setting, she may also be required to pay a copayment for the hospital for each rehab session. In some instances, a doctor might also recommend more sessions that Medicare is willing to pay for. Keep all of these into consideration as you are thinking through the location of where the services are. If you have a choice, you might be able to reduce your cost by getting it in an office setting versus an outpatient facility. And talk to your provider about the number of sessions versus what is your plan covers to see if there's going to be additional out-of-pocket cost you can prepare for, or there'll be alternatives or an appeal option to ask for more time. So steps to take for out-of-pocket medical cost. So I shared earlier about the Medicare savings plan that I strongly recommend. So while this could, depending on the type of savings plan and her income and asset level, there's a possibility that she might be eligible and it would help pay for some of those out-of-pocket expenses. And even if she did not qualify for one to cover her deductibles or co-payments, if she qualified for one for premium, it might help offset just enough to make these more affordable. Lisa can contact her state Medicaid program to discuss eligibility or apply online. I also encourage to screen for full Medicaid to be if you're dually eligible, and that is based on financial and income assets as well, a little more stringent and less than a Medicare savings program. Also looking at whether the rehabilitation program has any charitable or financial assistance. We can inquire about that, or sliding scale fees or payment plans to help alleviate some of the upfront costs to ensure that she gets the quality care that she needs without any restriction. Some community organizations offer financial assistance for healthcare expenses. Talking to the social worker, provider, or even a national charity like our organization, Patient Advocate Foundation, can help with navigating some of those benefits or solutions. And then it's always important to be transparent and discuss financial limitations with the prescriber. Explain the challenges that you're facing with the affordability of these things. There might be alternatives. Maybe there's a home health-based pulmonary rehabilitation program that's less expensive. We want to make sure that you get the care that you need and are not burdened by the cost that can hinder your ability to get well. Let's go into another case study with Mary. So Mary is a 63-year-old. She's enrolled in Medicare Advantage plan. She is challenged with delays in receiving necessary specialist care due to a prior authorization requirement with the Medicare Advantage plan. It's leading to poor control of her COPD symptoms. And the issue is that her COPD has become harder to manage. Her primary care has referred her to a pulmonologist for specialized care. However, the Medicare Advantage plan requires prior authorization for these specialized visits. The approval process is taking several weeks and delaying her access to the specialist. And during this time, Mary's experiencing worsening symptoms and ends up visiting the emergency room twice, which would have been avoided with more timely care. So understanding plan structure and networks. So let's just talk about a couple key areas right here. So this is a good visual indicator of kind of how a network can matter. So structures impact premium amounts, cost sharing, reimbursement, availability of providers and network, as well as paperwork, processes, and more. And there's so many different types of plans in the marketplace. So while I've included a host of different plans, if we particularly look at Medicare and Medicare Advantage, your Medicare is a fee-for-service, which gives you the opportunity to go to any provider that accepts insurance, and there's not a referral mechanism needed. Whereas a Medicare Advantage plan could have a PPO or an HMO version, and the HMO version would require you to have a primary care established, and that primary care then has to generate a referral to a specialist and gain approval through the insurance. Sometimes specialists need referrals even when you have open plan networks like PPOs due to the volume of patient need and the specialist wanting to ensure that you are aligned with the right specialist. But that is not an insurance indicator. So what steps could Mary take? So what Mary should do is talk to the provider, and the provider can intervene. I'm hopeful that Mary's provider knows that she's been at the emergency room a couple times, but if not, that's a really critical information to share, because the provider can reach out to her Advantage plan and request an expedited review. He can emphasize her worsening symptoms and potential for further complications if timely treatment is delayed. The other alternative is if there are continuous delays within the Advantage plan that she carries and she finds routine challenges with finding access to network providers or being a hardship with prior authorizations to get to care, she could consider switching to an original Medicare plan during open enrollment. So with original Medicare, she can go to any specialist, like we mentioned before, without authorization as long as they accept insurance. Now remember, if she does not pick a Medigap plan, then she still has that 20% out-of-pocket cost and may lose some other benefits that were maybe additional perks that carried with the Advantage plan. So there needs to be some thoughtful consideration as looking at those plan choices. I did not mention earlier, and I should have when it came to Medigap plans. So the guaranteed issue is it has been designed around those that are aging and retiring at the age of 65. There are some states that do have provisions for disabled Medicare beneficiaries, and they vary state to state. At the end of our presentation, I'll be sharing a link for you to kind of evaluate what that is. And there are also some states that will allow individuals to enroll into a Medigap plan even when they have not done so at the initial onset of their eligibility for Medicare. So Greg is a 55-year-old, is enrolled into a Medicare Advantage plan. He has formulary restrictions that limit access to effective medications, and now his COPD is worsening. So the issue is Greg's COPD is worsening, and his pulmonologist prescribed a combination inhaler to help manage the condition more effectively. However, his plan does not cover the specific brand his doctor recommended, insisting on a lower cost alternative that Greg has tried before with poor results. Unable to afford the prescribed inhaler out of pocket, Greg's COPD remains uncontrolled, leading to frequent flare-ups. So I want to talk a little bit more about formularies and medication tiers to help bring a better understanding of what's happening here. So a formulary is a list of prescription drugs covered by a prescription drug plan or another insurance plan offering prescription benefits. It can also be called a preferred drug list. On your insurance card, you'll see an RX with a bunch of numbers and letters titled to that. That's the information they use at the pharmacy and such to process the claims. But in addition, your plan itself will actually tell you what your covered medications are. This diagram here is in kind of a visual indicator of how they tier them. There could be tiers as high as 6, sometimes more, but a tier 1 drug is most but almost always generic, so it's usually the lowest copay. A tier 2 can be a preferred or a brand name medication, moderate copay. A tier 3 is a non-preferred brand name prescription drug. It has a higher copay. Tier 4 could be specialty. And then to the side, there are uncovered drugs. So sometimes the medications aren't on the formulary at all. So I'll dive a little bit deeper into also what was going on here. So we talked about formulary and we talked about tiers. So there's also step therapy, which was what's also happening here with this case example. It's a requirement to try an alternative medication first before they authorize or consider an alternative medication. This is often a cost control measure, and it is they want to ensure that other treatments have been tried. There also could be quantity limits, so in the amount of medication that you're allowed in a certain period of time, maybe an example, 30 tablets per month. There could be prior authorization that's also built in. So the same thing that we heard with our case example before could also apply for medications. And the higher that you go up the tiers, the more likely that you will see that occurring. So what could Greg do? So he can appeal the situation. They can ask for an exception and or appeal the situation because he has already tried the medication that they're wanting him to try. Sometimes they lack record. He might have changed plans. They might not have the information. And so if his medical charting can substantiate and support that, it's a real strong argument to submit to a letter detailing why the prescription inhaler is the most appropriate, how come the other one did not work, citing medical evidence, previous guidelines, etc. If there is an alternative medication that the doctor feels is that they are clinically wanting him to try, that's on the plan formulary, they can go ahead and put a request in for that to see how effective that is. And if that's not effective, that's also secondarily an argument that can be made about why the primary prescription that was sent would be necessary. And because it's not on formulary, you're asking for an exception to that because none of the other formulary drugs are working. You can inquire with the manufacturer. So say you go down this level and they still say, nope, we're not going to approve this off formulary, you're out of pocket, the appeal's denied, your exception is denied. You can go to the manufacturer and find out about any of their patient assistance programs. And they may have a free medication program. And if you meet financial guidelines and cannot obtain it through the insurance, may be eligible to get that through that means. We talked about this earlier, but switching plans. So if there is a better plan that has the coverage of the medication that Greg needs during those enrollment periods, that would be an ideal opportunity to change. So depending on where we're falling in the year, this could be something he could do now for it to be effective the following months, or it might have to wait until those open enrollment periods are. But it's always good to keep all of these things in considerations, because when your open enrollment periods do come, even if you're happy with your plan, you want to look at what your current care and treatment is and what your projected care and treatment is, because there are going to be changes. And just because it covers it now or doesn't cover it now, it doesn't mean it won't change in the future as well. So just like to put that out there. So I mentioned patient assistance programs, so I jumped a little ahead of myself, but the patient assistance is kind of a all-encompassing name when it comes to several different charitable assistance programs. But you have free product, you have copay cards and coupons, and you have charitable patient assistance through 501c3 organizations. Patient Advocate Foundation's Copay Relief Program is one of 9 different charitable organizations that I will show next. But one key point that I need to reference is that copay coupon manufacturer copay cards are excluded to those that have government insurance. So those that have Medicare, Medicaid, VA, TRICARE benefits are not able to use those benefits. There's just a restriction behind that and why the others might be valuable. I also will just put a little tip out there. It should never cost you to get a discount or any kind of cost savings off a charitable card. I know there's a lot of them out there, and so I just like to say that to caution people. You shouldn't have to pay for the discount card or pay for a service to enroll you into these programs because they're free to do. I also want to share with you the different national copay charitable programs out there, names and phone numbers for you for reference. They are income eligibility guidelines. There are disease funds. They may or may not support COPD, but I do want to bring them to your attention to screen. There's also an asset called Fund Finder that you can actually log in and create an account and put in the type of diagnosis that you have, and it can send you alerts when there's new funding available to any of these charitable programs. My last example is Frank. He is 68 years old and is enrolled into Original Medicare. He's been balancing financial concerns with medical recommendations for his rehabilitation and addressing his fears about insurance coverage for a skilled nursing facility. He was hospitalized after a severe COPD flare. His doctors recommended he be discharged to a skilled nursing facility, also called SNF, for a short-term rehab and respiratory therapy to stabilize the condition before returning home. However, Frank refused, really worried about the Medicare may not fully cover the stay, and he prefers to recover at home. So despite the CARES team assurance about the importance of additional rehab and the potential out-of-pocket cost, he was reluctant to leave. So let's take a minute and to go over Medicare Part A coverage and cost. So because he was inpatient and they want him to go to a skilled nursing facility, that would be covered under Part A. So you'll see that he would have, if he hadn't already, he would have accumulated a deductible of $1,676. And for the first 60 days of his stay, it would be zero. So depending on the length of his stay, these are the kind of the breakdown of the cost. For a skilled nursing facility, it's zero for the first 20 days of each benefit. So depending on the knowledge and education that he had around this might have been something that would have been ideal and beneficial for him to know and maybe made him feel more comfortable about that cost associated. So what could we do to help with his financial concerns? So some skilled nursing facilities and hospitals have financial aid programs. They call them different things: financial assistance, sliding scale, charitable assistance, Inquire. These are more public facing and forward facing now. You'll often see them in like flyers when you're being admitted. They bring them into conversations when you're in your medical bills and such. So timely discussion about that and being okay. It's all right to inquire and find out about those things. Explore the Medicare Savings Program. I like to repeat that because I think it's important. We don't know, like, where is his income and asset level? Are those benefits? Would it immediately help this current situation that he's hospitalized and moving forward? No. But would it potentially help him in the future with some out-of-pocket costs? Making sure that he's enrolled into all safety net programs. And discuss home health care. He wants to be home. That's his comfort. Are there opportunities for him to receive skilled nursing care and rehab services at home? And would that be cheaper? So Medicare does cover home health care under certain circumstances, and home health agencies work with hospital discharge planners to find reputable home health agencies. So all these things are worth considerations and doing like a comparison on the best course and making sure that he accesses the care that he needs and that at the same time we're addressing the concerns that he has. I want to share this resource. So I talked about charitable care, financial aid, all those types of things, but there is a really good resource that does it for you. So if you have hospital bills that are associated to a federal funded hospital, this $4 could help screen you and find out if you are eligible for any kind of charitable relief. It's all done digitally. And the link below is the one that they provided to our organization to provide the patients that we are serving or speaking to. But they're trying to take the administrative burden away from you and help those that qualify get that discount they deserve. So as I close, I want to share some external resources that I spoke about today. So Medicare, Medigap, Extra Help, Medicare savings programs, Medicaid, $4, a state health insurance assistance program, which is called SHIP. That's a group of people that are volunteer trained to understand Medicare and help you with your enrollment, any kind of questions you have around Medicare. And PAF, or Patient Advocate Foundation, we have a very robust educational resource library that you can access on our patientadvocate.org website. We also have a very specialized Medicare resource center that we have housed all of the resources around Medicare, including the new changes within Medicare Part D that I briefly spoke about, and a much more robust conversation around the guiding you to making your choices, an interactive training series on Medicare, tips on open enrollment, choosing a Medicare plan and prescription payment plan that I spoke about earlier, and more. I encourage you to visit that. If this topic is one of complexity, it's confusing, do seek out support from others if you need so. But I do hope that you found value in today's webinar presentation and appreciate the opportunity to talk to you today.
Erin, thank you so much for joining us today and for walking us through these coverage options and guiding us through some of the common issues that people with chronic conditions may experience with insurance, including both Medicare and Medicare Advantage plans. And thank you, everyone else, for joining us today on COPD and Medicare Made Simple, Understanding Your Benefits. We hope that this presentation helped guide you through what to do when you encounter some common issues with insurance. For more information about COPD and other chronic lung conditions, please visit the COPD Foundation website at www.copdfoundation.org. Take action today, breathe better tomorrow.